All right, Dr. Emerson, thank you for joining us today. Today I'd like to talk about Bivalirudin versus heparin for ECMO and bypass, and also about some topics about heparin-induced thrombocytopenia. With that in mind, what do you think about heparin versus bival for bypass?
I think there's a good number of reasons why heparin continues to be the gold standard for virtually anything we're doing involving a bypass circuit, and whether it be ECMO or full cardiopulmonary bypass. Heparin has a long track record. We know how it works, and there's a very easy way that's reproducible to reverse it with protamine. Additionally, the cost of heparin and institutional kind of comfort with heparin is usually very, very good. Obviously, there are some downsides to heparin, including the risk of developing heparin-specific antibodies, which lead to HIT, which can be a big problem in patients, and the potential risk of continued use of heparin with dropping down and getting an acquired antithrombin deficiency. But in general, through the thousands and thousands and thousands of patients we put on every year for long-term or large dose heparin, most of them do very, very well with that drug, and that's why I think it continues to be kind of the gold standard that we use on a daily basis.
Great. Are there any situations in which you would choose to use Bivalirudin either for ECMO or for normal pump run?
The most common reason we run into for that is with HIT. So patients with heparin-induced thrombocytopenia can be extremely challenging to manage, not just because we can't use heparin on them, but because the risk of thrombosis and these things makes it very, very challenging. And in patients where we have they have a HIT history and we have plans to go to bypass, I actually have one that I'm waiting on right now, we will plasmapheresis them, or we can do other things to desensitize them and be able to get them through a dose of heparin.
Oh, wow.
But in other patients, like ECMO patients who require some sort of anticoagulation, you can't pause it, you got to do something. Switching to bival or some other agent, and one of the direct thrombin inhibitors is typically what we do.
Okay, well, that's a great segue into my next question, which is, are there differences in anticoagulation when you're considering ECMO and bypass?
Yeah, I mean, it's a great question. So there definitely are. We typically, and you've seen that the target range for anticoagulation is much higher in full bypass. And so the ACT that we shoot for is somewhere around the like the 450 or greater range. Every institution may be a little bit different. And with ECMO, we shoot it a little bit lower. We will shoot in usually around 150 to 200 range for the ACT, if that's what your institution follows. And the reason for that is many, but part of it is that ECMO is a closed system. So there's not any open reservoir with an interaction with air. There's less damage to the red cells often that you see during ECMO, less activation of potential clot, and there's no roller pumps at ECMO, there's no open cardiotomy suckers in ECMO, those sorts of things. And so we can run our ECMO circuits at a lot lower level.
Okay, great. And then for my final question, we talked a little bit about HIT, heparin-induced thrombocytopenia earlier, but do you have any tips and tricks for when you're in the operating room or even in the post-op, cardiac ICU after operation to diagnose HIT?
Yeah, I think it's important to have a low index of suspicion and have it in the back of your mind when somebody's not doing the things you expect or having clotting issues that you wouldn't anticipate. We see it most chronically in patients who have longer exposure, so patient on ECMO for multiple days, a lot of heparin. Those are the ones that are certainly of a higher risk profile. One of the challenging things is that if you test a PF4 antibody, which is the initial test that we often send for these patients, which detects antibodies directed against the PF4 heparin complex, that's going to be positive in maybe up to 40% of patients who have big heparin loads, like anybody going through cardiac surgery. And so it's not a great test because of, even though 40% of them may have antibodies, only about 1% of them are actually going to have HIT. And so we are careful not to immediately shut off heparin if a PF4 comes back positive, unless we have a really high concern. We'll often wait for a confirmatory test, which is the SRA test, the serotonin release assay.
Okay, great. Well, thank you for meeting with me today and talking about this amazing topic, and I really appreciate it.
Happy to do it.
All right.